Nice seeing you too.
Yeah. So it's 12:05. So good afternoon, everybody. Welcome to Pan American Trauma Society International Telegram Rounds. This is year 13 or this important meeting for our society. Some faces here, some people here has been here for 13 years. And some are here are new, and that's very important to keep disseminating the teaching, friendship around the world. I would like to ask Maya to introduce the presenter and to invite the panelists to join this conference. Thank you, everybody, for joining this meeting. Maya, please.
Thank you, Dr. Martos. Good afternoon, everybody. And once again, I welcome you all to today's session of the Teletrauma Grand Rounds. So today we have Dr. Roberto Cortez, who is a surgical critical care and trauma fellow at the Jackson Health System Ryder Trauma Center. And he's presenting a case titled The Man Who Cried Wolf. And I guess everybody is very interested and intrigued by the title. So I'm gonna hand it over to you to start the presentation. And
thank you, Maya. Congratulations again.
Thank you.
So I'll just start by saying that I'm very honored and privileged to be able to share some of the cases we see at Jackson. And the last time I joined was for the motorcycle diaries with the devastating trauma we took care of. Before coming and starting fellowship here, this was a very exciting opportunity for us to be able to share some of the cases we see on a day-to-day basis here at Jackson, but then also discuss them in terms of their management strategies on a world stage. So I'm very excited and honored to be invited to present this. So this was a case that was presented at this year's Florida COT Florida Man Case Competition, which, as I mentioned earlier, is a collection of interesting and unique and unusual cases that the citizens of Florida typically find themselves in. And I haven't really changed much of it because I did keep some thematic elements, as you'll see, related to wolves and bites from dogs or canines and Halloween and full moon. It was very interesting time to take care of this patient. It was a perplexing case, and I hope that you enjoy it. So let's get started. So the case starts, it was actually the day before Halloween. It was a humid morning, an early morning, when we had a 56-year-old man who was walking to work. It was around 4 a.m. I did check, it wasn't a full moon, but he was walking on his usual route to work, which he takes every morning. Now, he was working at a resort in South Florida. This was his daily commute. Early morning before the sun comes up, he takes the same path every day to work. And otherwise, benign medical history, healthy patient, no problems before. And around that time, he was attacked by several large wild animals and sustained significant injuries, and was actually helped by a bystander who was nearby to help get away the animals who were attacking him, sustaining numerous bites on his way to work, and a very unfortunate morning for him, of course. He initially went to an outside hospital. He was then transferred to our trauma center via EMS. So this was actually a case at Jackson South that we saw last October. Upon arrival, his primary survey was intact. He had an intact airway, equal bilateral breath sounds. We secured peripheral IVs, and while we did see a large number of puncture wounds and a degloving injury to his scalp, there was no ongoing external hemorrhage. He was GCS 15. He was moving all four extremities, and his index vital signs were as follows, with a heart rate of 101, blood pressure of 100, tachypnic, and on 4 liters nasal cannula. His index chest x-ray is as seen here with no obvious hemopneumothorax, and his pelvic x-ray as here. He did get a FAST, which was also negative. Now, I tried to sketch out in terms of the burden of wounds that he sustained upon arrival. The most pressing ones were a large degloving injury of his scalp, multiple injuries to his face and left orbit, his shoulder, his arm, down through his groin, bilateral lower extremities as well, presenting with a pH of 7.17 and a base deficit of -11 and a crit of 42. So some are just in terms of the mechanism of presentation, his vital signs, and his initial resus with some discussion about the panelist's prior experience with these injuries, these dog bite injuries, and how he's presented so far.
Thank you, Dr. Cortez. Dr. Andrack, do you want to make your comments first?
Certainly. Well, so I assume that, you know, if he's up at 4 o'clock, he might not have had anything to eat or drink since dinner the night before, or certainly the numbers suggest that there's no external bleeding, no internal bleeding, and he is a little bit hypovolemic and underperfused. So he needs to be resuscitated with about 1.5 liters of crystalloid and see where he stands at that point. I don't think he's going to need blood transfusion. And then once his vital signs stabilize and he's no longer tachypnic and slightly tachycardic, then I think you can address the all of the wounds, irrigating and cleaning out the wounds and dealing with them, having ruled out what looks like no internal injuries. Also about the extremities, you didn't mention, but I assume all the pulses, the neurovascular status is intact in all 4 extremities, so that'd be important to confirm.
Yes, pulses were intact.
Right.
Thank you. Fine.
Right, and then the other 2 things are tetanus immunization and also consideration of rabies. And since you don't know if they were wolves or what they were, but that's also unprovoked attack by animals, and you don't know the status, so that's also a consideration. And most mammal bites, if they're canine, they need broad spectrum antibiotic coverage, but most importantly, cleaning out the wounds.
Dr. Frisbee, do you have any comments?
Can you hear me?
Yes.
I think that's exactly what I would do. He's awake, alert, and oriented, and apparently he just got on the wrong side of it. It just wasn't his morning, unless, you know, he was down on all 4s when he was walking to work. But the point is, that I wouldn't change anything there. I think that's the appropriate way to start.
Thank you, Dr. Frisbee. Dr. Evaturi, do you have any comments to add?
Yeah, I agree with everything that has been said. I think he's very thorough in the initial assessment and resuscitation. My only concern is the scalp lacerations described as degloving injuries. Exactly what does that mean? I mean, the whole scalp has been pulled off, and that can be a significant source of blood loss. So was there a loss of a lot of blood at the scene? So I would consider that, you know, getting some blood transfusions after the initial crystalloid resuscitation. That may be very much in order, and repeat your blood gases to see if you're proceeding in the right direction. And all the considerations as well has been described. But one thing we need to be very careful about is whether there is any myoglobin in the urine causing some problems later on in the renal failure. So there is something I would check as a baseline. So keep track of it. So those are things I would add. Thank you.
Thank you, Dr. Evaturi. Dr. Hodgman, do you have anything to add? I think you're muted, Dr. Hodgman. Can't hear you.
Sorry, you treat this patient as a typical trauma patient. The regular priorities. My only concern is, does the chest X-ray has pulmonary edema or not? I don't know if it was technique or not, but appear to have some pulmonary edema on the chest X-ray. It doesn't appear to be an underpenetrated chest X-ray. It would be too early for pulmonary edema, but it's kind of, maybe, I don't know. That's all I have at this time.
Thank you.
And I would probably console ID. Did they identify the animals? What was this? Coyote? I am thinking the things that can, I live in the Northeast and I live in the countryside. So I was thinking the things that can come in a pack and attack you at night. It would be coyotes will be the first one. And raccoons, maybe? I don't know what you have in Florida that can attack you at night when you are walking. I really don't know. But it depends on that, if the animals were identified.
Thank you, Dr. Hajman. Dr. Kasim, can you hear me?
Yes, I can. Good morning.
Good morning.
So we were taught the moral of the story behind the man who cried wolf is never to tell a lie, but that's not quite true. The moral of the story is you don't lie the second time. That's when you get into trouble. So looking at this case, I think I agree with Dr. Professor Ivan Turi. A scalp lesion can cause profound blood loss. Hence, I would not avoid blood transfusion as such. In fact, I would keep that in mind that the man may have lost considerable amount of blood before coming to the emergency room that you may not be aware of. Other than that, I don't have anything further to add at this moment. Thank you.
Thank you, Kasim. Dr. Martos, do you have any comments?
I know the case, let's keep going.
Okay. Okay, Dr. Cortez, back to you then to continue.
Thank you all for your wonderful comments and insight, much appreciated. So just to talk about some of them, as we said, the scalp degloving injury, it was very focal along the right frontotemporal region with a small skin flap that was elevated and some exposed galea, but no active bleeding. So that was irrigated extensively, but head to toe, there was no ongoing external hemorrhage. Thank you for raising the points about tetanus prophylaxis, as well as rabies. All those were initiated immediately in the ER. So we did start those interventions as well. So moving on here, just wanted to go over some of the imaging here, which was read as aside from subcutaneous emphysema around the sites of the bite wounds, particularly in the right upper extremity, which you can see here. Distal neurovascular examination was intact. And then there was a formal read by radiology as no acute traumatic process in the chest, abdomen, or pelvis. And I just wanted to glance through it quickly, and this was read as a negative scan. However, and this was given the early morning time frame of the traumatic injury that he sustained. I was actually in the oncoming service that morning, and I saw him with my attending at the bedside, and he was another point I should raise is some consultants that were involved when we first evaluated this patient at the bedside in terms of helping to wash out and irrigate his scalp wound. He also had OMFS and ophthalmology there first thing in the morning to take a look at the extent of the injury over his left eyelid with no orbital involvement there. They were also approximating and irrigating the scalp wounds and investigating some of the wounds on his face. However, we saw when we did our first assessment, we examined the patient head to toe. Distal neurovascular examination remained normal with palpable pulses. However, we saw gross hematuria, which had not been identified previously, but it was a pretty good amount of blood at his meatus, which, as I said, was not identified or maybe hadn't really presented itself previously. So now we had a patient who had already had imaging performed with no identification of the hematuria. And we really started our secondary survey essentially from scratch at that point to see if there were any missed wounds, missed bites anywhere else. So with this new clinical information for this patient and given the imaging that had been performed, I'm curious as to what the panelists would approach this problem as now. If I will say that externally, his penile region, his scrotum was examined extensively, and we actually did note a single puncture wound over his right groin right here. And so having that information, I'm interested to see what the panelists would do next.
Thank you, Dr. Cortez. Dr. Evathuri, would you like to comment?
Yeah, it's very puzzling. Can you show us exactly again where the laceration was in the groin? And can you describe it, how deep it is and whether it has extended to the flank?
Dr. Cortez, we can't hear you.
Oh, I apologize. So not extending to the flank as a single puncture wound that was less than a centimeter in size, not actively bleeding, located right around the area of the right inguinal canal.
Okay. Okay, I would go back to looking at the physical examination again and perhaps repeating a scan or this time maybe an intravenous pyelography to see if there is any extravasation from any of the trajectory ureter, even though it's unlikely. So it's most likely it's coming from the bladder, looking at the site of that injury in the right inferior fossa of the abdomen. So, so intravenous pyelography with the cystogram or a cystourethrogram would be my next study. And the patient, I take it, has been stable, otherwise.
Yes, sir. Otherwise stable.
And you mean real hematuria? It's not something else masquerading as blood, as red in the reddish tinged urine.
Yes, sir. It was frank blood out of the meatus.
Okay, thank you.
Thank you, Dr. Azzuri. Dr. Kasim, do you have any comments? Dr. Kasim, we can not hear you.
Sometimes methemoglobinuria can mimic hematuria, but you actually saw red blood cells in the urine. At least the people in the lab probably called you and told you this is red blood cells in the urine, hence it makes it hematuria rather than anything that mimics hematuria. So I think I would put a Foley catheter in and look at the urethra and the bladder. Make sure that the fangs of the animal did not penetrate the groin into the bladder area, thereby causing a latent injury that you have missed or we have missed at the initial examination. And that shouldn't take very long. You can do that expeditiously, even a single scout film. Put a film under the pelvic area and shoot and see, get a quick examination of the bladder area. Looking at the CT scan, the patient seems to have bilateral kidney and the ureter seemed to be intact. So that's what I would do.
Thank you, Dr. Kasim. Dr. Frisbee, do you have any comments?
Well, if you know it's blood, there's one or two things you can do. You can do a retrograde cystogram, or you can either take it upon yourself, if you've ever done one of these, and do a cystoscopy. You know, gently slip the scope up there and see if you can actually see a puncture wound, a penetration of the bladder. Or you can call the urologist. Sorry, but you can call the urologist and have him do it 1, 2, 3. Barring that, the only thing I can think of is probably a one-shot IVP and what goes with that ureter. But that's all I have.
Thank you, Dr. Frisbee. Dr. Hodgman, do you have any comments?
No, I'm completely puzzled by this. It's near the cord. So it is hematuria when he urinates, or it's just blood coming through the meatus?
So what we saw was just coming out spontaneously. It was not with urine.
Spontaneous from the meatus. So I would say maybe, but this is kind of like so weird that the spermatic cord was injured at the same time of one of the veins in the cord and is bleeding that way. But this is so weird that I doubt very much that that could be the reason.
Was it bright blood, Dr. Cortez?
It was dark blood, actually.
It's a dark blood, okay. So is there some fangs like was described has gone through the femoral vessels on the way to the bladder, and that is caused a bleeding into the bladder from the vessels. So there is some other consideration you want to think about.
Dr. Anshai?
Yeah, but the bleeding is happening without the patient urinating. Is this correct, or I misunderstood you?
Yes, it was just spontaneously coming out of the meatus at the bedside.
Yeah, so I don't know, the guy might have a varicocele and kind of bled into the, but this is extremely weird.
Dr. Anshai, do you have your?
Yeah, so right. So I was thinking along the same lines as Dr. Hockman, because you said the patient is basically incontinent of blood. It's not hematuria, but just blood streaming out of the meatus. So you're seeing where the puncture wound is, you can kind of guess that maybe there was a injury to the veins of the spermatic cord, or as Dr. Iventuri says, the femoral vein and the nearby vas deferens, and then there's blood flowing that. But that seems pretty far-fetched. I've never heard of that happening. Why blood would preferentially flow that way and not just get a hematoma in the groin. But in any event, you did the FAST exam, but I would look again, because when you look in the pelvis, if the bladder were full, you'd normally be able to see if there are clots. You would notice right away clots in the bladder. But I would look again for clots in the bladder, especially if the bladder is full, and then for evidence of bleeding. Currently, you didn't see it initially, but if there's bleeding around the bladder in the extraperitoneal space, you should be able to see that by ultrasound, and then everything that Dr. Frisbee said, you can do retrograde cystogram to see if there's a leak from the bladder, whatever. But initially I would look again with the ultrasound, put a Foley catheter in, and wait for see if the urine itself is bloody. If it is, some IV fluids, wait for it to clear, see how is acidosis and corrects, and where his hematocrit settles out. But I would do all of those things. I wouldn't get I wouldn't get overly worried about it, but I would if you put a Foley in and it clears, then probably there isn't nothing terribly urgent about it, but it's a little bizarre.
Thank you, Dr. Anshai. Okay, Dr. Cortez, back to you to continue.
Thank you all. Yes, you shared our puzzlement. We're a little perplexed by this case, and thank you for all the insight, the tips here. We did not do another FAST, but I think that's a great mention to look at, see if there were any visible clots within the bladder. We did, however, elect, as you mentioned, to perform a imaging study to see if there was any evidence of a bladder injury here. Let me see if I can get this to play here. And didn't see anything there. But we looked at two very interesting points here now that we drew our attention. Really, this is kind of the interesting thing of focused assessment of the CT scan, which I said was initially read as normal. And so we shared the panelists, puzzlement here, and then we went to the radiologist.
Sorry, but there is a blush near the cord.
Yes, yeah, thank you. Yeah. So again, as you pull your attention towards the cord, we found what I will say. Let me see if I can get this pointer off here. Just a second. So now the initial CAT scan, we're laser focused, obviously, on the right groin, given the new physical exam findings and this area of concern, particularly near the right spermatic cord. So we draw our attention here. We actually do see a hematoma along the right spermatic cord with this hyperlucent object lodged within the cord itself. And I'll kind of go back to it here, which you can see right around there. And we looked at it for multiple views, went back with the radiologist because it wasn't mentioned in the initial read, but we were concerned here. And there's two cuts, the axial and then the coronal cut, where you can see there is in fact a hematoma within the spermatic cord dissecting along the cord. And there's something that looks like a foreign object that's lodged within the cord itself. So now we have a potential source here, and we're discussing back and forth management strategies for what we think. So I'll start with that and say, now we have a finding on clinical examination. We have a finding on CT scan. And we were discussing amongst ourselves and the team that was on call what to do next. And what this could be, first of all, what this could be, what are the potential clinical implications and consequences of this, and what to do next. So I'll leave that, leave us there for the panelists to discuss some more.
Thank you, Dr. Cortez. Dr. Kasim, do you want to make your comments first? Dr. Kasim, we can't hear you.
Did you by any chance listen to this area to see if you hear a brewery, which may suggest you have a fistula between AV?
I think that's a great point, Dr. Kasim. Thank you. We actually did not listen for a brewery, but that's an excellent point.
Well, I don't know. I'm wondering whether there's actually a foreign body. And maybe the fangs of the animal broke off and got embedded in this area and caused an injury to the vessels. But if it is, it should have shown on the CT scan, because teeth shows up on CT scan. No, I'm puzzled. Like the professor from Boston, I'm puzzled. Thank you.
Thank you, Dr. Kasim. Dr. Hodgman, do you want to make your comment?
So I think that what I would do in this case, I would probably explore for two reasons. One, to control the bleeding and see the damage. And two is, if that is not a blast, if that is showing it before the injection of IV contrast, the most likely thing you have there is a tooth. So I would remove that tooth and send it, because we have a veterinary school that we work close by, and I would send it to the veterinary school to see if they can identify the animal who bit this guy, because that seems that would be useful. Thank you.
Thank you, Dr. Hodgman. Dr. Anjay, would you like to make your comment?
Yes, I agree with that. And but first, the first priority is taking care of all the large wounds, really clean them out very well, and deal with them, and then also explore the groin. I don't know if you do surgical residents do a lot of open inguinal herniorrhaphies these days anymore? Are they all laparoscopic?
Throughout my residency, did a fair number of open inguinal hernia repairs. Yes.
Yeah, it's right. It's a great intern's case to explore the groin, but just open the inguinal canal, like Dr. Hodgman said, look at the vas, and he's 56. He probably doesn't care if you're going to repair it. If it's easy, you go ahead and put a stitch in the vas if it's been damaged. And then ligate any venous bleeders, and I agree, that's the most likely a tooth. It's really part of the examining the wounds to look for retained foreign bodies in any of the wounds. In fact, the left shoulder looks like there was some scattering foreign material superficially in the CT scan, but that would have washed out easily, when you clean the wounds. But I think that's the approach: is explore the groin after taking care of the main wounds, and then clean out the groin.
Thank you, Dr. Anjay. Dr. Frisbee, do you have any comments?
No, I agree. I think it's an object that most probably is a tooth. One of the dogs is wrong in the tooth. I just have to, explore it and see what I found.
Thank you,
That's all.
Dr. Frisbee. Dr. Avithuri, do you have any comments?
Yeah, let's go back and look at what's happening with this guy now. How do you explain the base deficit of -11 if it is just a very localized bleeding in the cord, in the right groin? Was there such a big hematoma to explain that blood loss? And so what are the repeat counts? What is his lactate? What is his base deficit doing? Was his repeat hematocrit? If they're still low, then you are missing obviously something else. So before you plunge in, you may want to repeat a very localized views of the CT scan of the right groin, focusing on that, trying to define whether there is some kind of a fistulous communication with a blood vessel that's keeping the blood loss active. So those are the things I would definitely consider before. He needs exploration, there's no question about it. But before I do that, I would like to have more information. And the foreign body, I'm puzzled from Dr. Hodgman why he's saying that it's very useful to know what kind of animal it is. So maybe he can explain that to us. And otherwise, yeah, I would be interested to see what the foreign body is. Most likely it is a fang or a part of the tooth of the animal. But those are the thoughts that I would go through before I would plunge into the operating room. Thank you.
Thank you, Dr.
I would like to know what type of animal. First of all, because I'm curious what it was there.
Right.
And secondly, I imagine, and again, this I plead my ignorance, that different animals can carry different type of bacteria in their mouths.
Right.
I know, for example, that raccoons can carry leptospirosis, which I don't think that coyotes can. So it might be useful in terms of determining the antibiotic treatment that the guys have to have. So I will discuss that with ID, but I honestly, if it was bitten by a raccoon or a coyote or whatever, I don't. When coyotes can carry tularemia, but I don't know. Kind of, I would probably talk to ID after that, after identifying, to see if something else needs to be covered.
Okay. Thanks.
Thank you, Dr. Vaturi. Thank you, Dr. Hodgman. Okay, back to Dr. Cortez. Dr. Anchak, do you have a comment before that?
Yeah, and I was wondering whether the public health officials need to know about these, if these are reportable. If you have animals running wild right in the middle of Miami, accosting the public, that they, that's maybe a reportable event that the animal control people need to know about, and might be helpful for them to know, what the animal was if you have the tooth. And I agree with Dr. Hodgman. You like to know as much as you can, so you let the patient know and the risks involved, and for public safety. So most of us don't see very many cases like this at all. So it's an unusual case.
Thank you, Dr. Anchak. Dr. Cortez, back to you to continue.
Thank you all for your insightful comments and suggestions. And this, we did reach out to animal control. This was actually in Homestead, Florida, around the area of Jackson South, about, let's say 30-45 minutes south of Miami-Dade. And I did not mention or include the repeat resus showed improvement of a significant base deficit after some fluid and some time. All the other wounds were irrigated extensively without any other concerns. And so he did improve his hemodynamic parameters, his resus values, before we decided what to do next. And as many of you did mention that you would operatively explore this, both for the risk of bleeding. Our concern was not only that, but also we did entertain briefly, I should say, but we did discuss the possibility of antibiotics in close observation. However, we were concerned that this is obviously a contaminated wound with a lodged foreign object within the cord. And if we were to fail non-operative management, meaning there was a significant progression of infection, we would be faced with a significant deep space infection tracking along the length of the cord, where, alternatively exploring now, gaining control of this and taking a look, we'd essentially be entering unviolated tissue planes. So we elected to explore the groin, and Dr. Untrack, you did mention the operative approach, which we chose, which is really just in the fashion of an open inguinal hernia repair on that right side. So we took the patient to the operating room, and then the images are up next here. So when we were in the operating room, there were no violated tissue planes on the way down. We did see a hematoma within the cord. Once we were able to mobilize that, we gently placed the tonsil through the puncture wound, and it freely passed right down to the level of where the cord was. And this was the track that we were able to visualize directly in the operating room. As we mobilized the cord in a standard open inguinal hernia repair fashion, we were able to see a small hematoma within the cord, and we can actually palpate a foreign object that was, once we mobilized the cord structures, it was embedded within the cord structures in some of the gonadal vessels, as well as adjacent to, but not violating the vas deferens. And so once we mobilized it out, we were able to actually extract this tooth here from the cord. And then we put it in terms to measure about 1 centimeter in size. So in terms of the panelists, just want to commend you. That's exactly what we found. We found a tooth that was stuck there with some bleeding. There was a small arterial bleeder that was ligated. It was very small. We did check with Doppler flow, the blood flow to the ipsilateral testicle, which was intact before we closed. We irrigated extensively, and then we were able to close the incision in layers and continue the patient on antibiotics postoperatively with no problems with wound infections after we completed the case. And then the pathologist gave them something to do in terms of looking at this, and they did say it was a fragment of a dog tooth that was just under 1 centimeter in size. The patient subsequently got discharged from the hospital with no issues. The rest of his wounds healed well with local wound care. He was undergoing physical therapy and occupational therapy, has since been seen in the office and otherwise doing well. He completed his rabies vaccinations. The animal control was notified and put out a search that morning. I wasn't able to follow up and see if the animals were identified in terms of what they were. But nonetheless, this was as I mentioned, a kind of a perplexing case around the area of Halloween. So I kind of kept the interesting nature of this dog bite and what it could be with him, but he's since done well, thankfully, and was subsequently discharged. I'll get into some background information, but I'd like to welcome any questions or comments at this time.
Yeah, I will go one round of the panelists for final comments. So, Dr. Frisbee, do you have any final comments?
No, good case. Very, very thought provoking. Did you ever find out how many animals? Or was it just 1 or 2?
I know it was 2 to 3 after we spoke with him, and we didn't get in touch with the bystander who helped him, but there was somebody along the trail that helped get them away and called the MS for him, and it was somebody thankfully was around, but it was at least 2, maybe 3.
So it's a pack animal. Okay. Well, you did a great job. Nice going, and keep the tooth. Very well done.
Thank you, Dr. Frisbee. Dr. Anjak, do you have any final comments?
Yeah, interesting case. So just a couple of questions. So for rabies prophylaxis, you got the vaccine plus rabies immune globulin, is that right? And then antibiotics, you're probably going to mention what he got. So I'll wait for that. And this is your operation doesn't really clarify how the blood appeared in the urethra, though. I mean, that's a little bit, an unsatisfying conclusion. And because otherwise, there's not anything that I've ever seen, heard about, or read about, and maybe for that reason, it might be a reportable case if you can explain how the blood got into the urethra, if it actually came from the right inguinal cord, the spermatic cord. But very unusual case, and it just shows how varied your trauma service is there in South Florida and Miami. So good for you.
Thank you, Dr. Anjay. Dr. Iwaturi, do you have any final comments?
Yeah, great case, very well presented. Did I understand correctly that you got a first place for this case presentation? If so, you totally deserved it because it was very nicely done. Very unusual case, as Dr. Antrak mentioned, and I think that's what makes trauma surgery so exciting. So you always see something new every day. So, and I think all the panelists' comments were spot on, and I hope we all learned a lot from that. So thank you very much for this.
Thank you, Dr. Iwaturi. Dr. Kasim, do you have any final comments? Okay, we cannot hear you, Dr. Gassim.
Well done case, but I have a question for Professor Venturi. What would happen if you leave the tooth embedded in that area and the bleeding stops?
Well, I think it will become most likely it'll be a focus of infection and form a big abscess there. And that might make things worse. It might go on progress to some fasciitis, necrotizing problems. So I think any foreign body like this, which is potentially infected, should be taken out, in my opinion.
Great case. Thank you.
Thank you, Dr. Gassim. Dr. Hodgman, do you have any final comments?
Very, very interesting and perplexing case. I know about the case, really kind of like you handle perfectly. What I was going to say is, if this would happen in the Northeast, we will suspect coyotes, because they are kind of like in the middle of the night, particularly scared. You will not differentiate that from dogs, unless you have feral dogs in Florida, which I doubt. These were probably coyotes, and it would be interesting if you send the tooth to veterinary school if they can determine the difference. Coyotes tend, obviously, it's most like the chance of rabies is much higher than regular dogs, assuming that they are not feral dogs. But that's the reason here. At least where we live, we always carry pepper spray when we are outside, because we have bears occasionally, very rare, but coyotes or bobcats, whatever, they are more common, and they might not attack humans, but they might attack somebody walking a dog, attack the dog, particularly if it's a small dog. So we all carry pepper spray with us when we go into the woods, or when I go mountain biking, I also do the same thing, just to prevent situations like this. Thank you.
Thank you, Dr. Hodgman. Dr. Cortez? Do you-
Yeah, thank you everyone for your comments. So just to briefly review, animal bites encompass about 1% of all emergency room visits per year, with about 30 to 50 deaths as a result. And as we can see, I think we actually had another brachial artery injury presented recently as a result of a dog bite. And this kind of perplexing case, a wide range of severity and clinical challenges present themselves after these injuries. 95% result from dogs and cats, primarily domesticated actually, with the infection potential with regards to Pasteurella, staph, and strep organisms. Not only do patients sustain the puncture wound themselves, but significant degree of blunt force trauma and degloving injuries, again, depending on what animal and what breed is involved. Frequently, they require multidisciplinary care, as we can see here, particularly with the wide range of areas of the patient that were involved, from the deep scalp wound to the eyelid laceration, urologic input for the hematuria, and then trauma surgery as well. Extensive irrigation and debridement is needed here, along with tetanus updates if necessary. And then the decision to close versus healing via secondary intention, given the high risk of these wounds getting infected. Frequently, the patient can be discharged, not in this case, but if it's a localized bite with no signs of cellulitis or infection, or the need for intensive wound care, can be discharged on a course of Augmentin for 7 days, Bactrim or and Flagyl or clindamycin or second line if there is a penicillin allergy. And then rabies vaccination was initiated in this case and frequently initiated in the ER, followed by updated vaccines on day 3, 7, and 14. But with regard to penetrating injuries themselves to the inguinal canal, we can understand there really is nothing online about these types of injuries. When you look up groin trauma, it very much focuses on injuries to the femoral vessels, the iliac, stab wounds, gunshot wounds, etc., in terms of vascular control. But injuries to the inguinal canal, much less encountered and really not written about at all. But we can extrapolate that multidisciplinary care, including urology, trauma, and general surgery, would be required to approach the care for these patients. A wide variety of mechanisms with injury to the gonadal vessels, the vas, or even the deeper vasculature, which we should be concerned about given the anatomic regions and vessels involved in the inguinal canal. And as we can see, the ipsilateral groin and examination there and a distal neurovascular examination are critical. So Dr. Untrack, as you did mention, it was kind of, I'm not sure if it was simply from the blunt force nature of the bite itself that caused traumatic change or traumatic insult to the vas itself that resulted in the hematuria. That quickly resolved. It was not a prolonged issue after the operation was done and throughout his hospital stay, but that was something. And then I quoted this, this was from the FCOT, the Wolfman quote from 1941. And then the team that was involved, Dr. Lenine and I took this patient to the operating room. And these are my co-fellows, and then Anna, one of our NPs who helped with wound care and making sure that the patient received his rabies vaccine in a timely fashion. And that's all I have. Thank you very much. Appreciate it.
Thank you.
Nicely done.
Bob, this was a nice case. I have a question to Dr. Hodgman. Does this pepper spray really works? So here, I'm from the city. So anybody here that experienced how to deal with this kind of encounter, have a bear or a wolf or a wild cat? So any recommendation how to deal with that to avoid to become a trauma patient?
It's a canister this big. There are ones that are specifically designed for bears, but those for bears are more for grizzlies, not for the black bears. The black bears that we might see here is very unusual that we attack humans. So the small one would work, and it's you buy it in I don't know, in big sporting stores or in a gun store. They probably sell them too, and they have a reach of like, I don't know, like 10 feet. And you carry in your pocket. There are different sizes, but the most common size is this big. And you carry in your pocket or in your hand. If you're walking at night with the dogs, you carry in your hand. And we always, particularly at night, we always carry that when we are walking the dogs. We live in a very rural area outside Boston. People think Boston is a big city, but Boston is not a big city. And you just drive 35 miles out and you are in the countryside.
Okay, thank you, Horacio. Okay, Bob, was a great case, great presentation. I see that Dr. Lanin is here connected. He was one attending the case. I see Dr. Hiroto, another fellow in the case, is connected. And Russo, thank you very much for your good work. And I really would like to invite all of you to contact Maya to schedule presentations for the next few months. Again, this is a nice meeting. We learn each other. Sometimes we do things different, but depends on where we are, but with the same goal to treat the patients the best as we can. So please contact Maya. Thank you very much. And see you all next week.
Thank you. Bye-bye.
Thank you. Bye-bye.